I'm just seeing from your nose up. Oh, all right, good. Perfect. Perfect.
30 seconds, Madam Heather.
Okay.
Valerie, can you take that screen down, please?
Okay, welcome, welcome, welcome. Welcome to another infection prevention and control series hosted by Omega Kappa chapter. So we are on to our fourth day of our infection prevention and control. If you were here last week, you will agree with me that we had 3 days of good presentation, excellent presentations. And I am sure that you all were reminded of something, or you received something that you did not know. As nurses, we are always studying, we're always refreshing our memories, and we're always seeking to be in the know. So this afternoon, we have 2 wonderful presentations lined up for you. But just before I begin, I want my nurses to just be obedient for about 2 minutes. So I just indulge you. I'm going to ask you to just indulge me for about 2 minutes and get your paper, a blank paper, and a pencil or a pen. So if you have your blank paper and your pen, I'm just going to ask you to just indicate in the chat. You can open your mic and say yes, or you can give me a thumbs up and just let me know that you have a piece of paper and you have a pen or a pencil with you. I'm not hearing anything. Let me see if I see any thumbs up. No thumbs up yet. Can you hear me? Okay, Nicola, thank you. Yes. Anybody else have a
Yes,
piece
I
of pen?
have.
Yes. Yes. A piece of pencil, a paper. Yes, Janelle. All right, another 30 seconds for you to just grab your paper, blank paper, and grab a pen or a pencil. And if you have a crayon, I'm fine with that. Okay, let's go. Okay, nurses, I'm going to just ask you to just be obedient. Have that piece of paper in front of you, and I'm going to ask you to close your eyes. Just close your eyes and think about something nice. Okay, with the pen or pencil or crayon in your hand and your eyes closed, I'm going to ask you to draw a circle. Okay, you're drawing that circle. Now I'm going to ask you to give that circle 2 ears. Okay, you have. I'm going to ask you to put, I want to hope that your eyes are still closed enough. All right, you're going to put a nose in place. And you're going to put a mouth in place. So for those of you who are just coming in with your eyes closed and a blank piece of paper and a pen or a pencil, you're going to draw a circle. Your eyes still closed. You're going to put in your ears. Your eyes still closed. You're going to put the nose and the mouth. Okay, if you have done that, just open your eyes for me. Okay, who is willing to tell me that they made a perfect face? If you made a perfect face, just open your mic and tell me that your face is perfect. Anybody? Okay. Anybody want to tell me what they're seeing? No, Nicola, thank you for answering. It's not perfect. Anybody else? Yes, Cheryl, LOL. Yes, no, it's not perfect. Anybody else want to respond in the chat? All right. Now, nurses. Mine is perfect. Okay, Andrea. Now, nurses, sometimes our patients and we ourselves, we are ill. And as far as we're concerned, we are perfect. But when we do the test, when we do the diagnostic test, or if someone was to ask us, see, you look so nice, they don't know what is happening inside. That is how life is, right? We're living in a space where things are not always perfect. What you see outside is not what is going on inside, right? So we're not perfect. So as we come today, we're going to hear about conditions that it's not perfect. All right. But knowledge is golden. And so our infection prevention and control is to remind you of some things that you were not aware of, or to let you know that, listen, things can be done differently. All right. So as we go throughout this series, just remember that we're to be gentle with each other. You don't know what they're going through. They look okay outside, but inside they might be having some heavy burdens that just a smile, just a touch or a hug can help. All right. So this evening, we have Miss Valerie Jones-Ellis. Valerie Jones-Ellis is a family nurse practitioner, rheumatic fever coordinator for Manchester, and 4 times National Rheumatic Fever Coordinator of the Year. She's a mother, wife, and an entrepreneur. She is the owner and operator of Gentle Care Mobile Nursing Services and the manufacturer of 3D's tantalizing wines in honor of her late sister. She is married to her best friend and holds the mantra, I can do all things through Christ who strengthens me. So just welcome now for presentation, Miss Valerie Jones-Ellis. Thank you.
Good afternoon, everyone. Let me just screen share. Can you all see my screen?
Yes, we can.
Awesome. All right, so good afternoon again. I'm Valerie Jones-Ellis, and today I'll be presenting on the prevention and control of rheumatic fever, rheumatic heart disease. I know for some of you, it might be a reminder, while for others, you'll be learning something new. By way of introduction, rheumatic fever, rheumatic heart disease is still a major public health problem in developing countries. It's most commonly acquired cardiovascular disease in children and young adults. Mainly affects children 5 to 15 years, but the disease may occur in younger or older individuals as well. It is caused by the group A beta hemolytic streptococcus, and in developing countries, there's a high occurrence of rheumatic fever, rheumatic heart disease. In developing country, the disease has a high rate of recurrence and severity. It also accounts for 12 to 50% of all cardiac patients admitted to hospitals. Rheumatic heart disease is a chronic disease which requires repeated hospitalizations and surgery and often leads to premature death. Almost half of rheumatic fever, rheumatic heart disease patients are unaware of their disease, and only 2/3 of these patients receive a monthly secondary prophylaxis. There is no anti-streptococcal vaccine, hence the most feasible and proven cost-effective methods of prevention is adequate management of all sore throats. The group A beta hemolytic streptococci is responsible for initial and recurrent attacks of rheumatic fever. Prevention of rheumatic fever, therefore, depends on the accurate clinical diagnosis and management of sore throats using the most appropriate antibiotic treatment. The risk factors for rheumatic fever include age, and as we said before, that this is the most common among persons 5 to 15 years old. It rarely affects children below 3 years of age and adults. However, it doesn't mean that they are immune from this condition. Another risk factor is the group setting. So rheumatic fever is most common in crowded areas. So where persons gather, like schools, daycare, those areas are high risk areas for rheumatic fever to be transmitted. Infectious illnesses, including the group A streptococcal infections, tend to spread wherever large groups of people gather. So crowded conditions can increase the risk of getting strep throat, scarlet fever, or impetigo, and thus rheumatic fever if they are not treated properly. And as I mentioned, that these settings include schools, daycare centers, military training facilities, and big yards as we know it. We have multiple families living in the same environment. Risk factors continuing, health factors where persons who had a past history of rheumatic fever are at increased risk of an individual having rheumatic fever again. So how do we manage sore throat? So now we know that rheumatic fever is not a condition of its own where it can be transmitted from person to person, but it is caused by an untreated or improperly treated sore throat. And so in preventing rheumatic fever, we are supposed to manage our sore throats effectively. Now, in managing our sore throat, penicillin is the treatment of choice. It's a gold standard. And also we want to prevent rheumatic fever by ensuring that our patients are compliant with their medications. For those persons who are allergic to penicillin, we give them the cephalosporins that will also eradicate the organisms from the upper respiratory tract. This chart is just highlighting the dosage of the penicillin and the other medications as it relates to benzathine penicillin. It can be given as a single injection and the dosage is there. And for amoxicillin orally for 10 days. So when you treat sore throat, it must be given for 10 days, the minimum 10 days. And these persons need to be reviewed. And if there's a need, can also extend to an additional 4 days. But for somebody getting amoxicillin, the dosage will be calculated based on the weight for children, and then there's a standard dose for adults. For those persons who are allergic to penicillin, they are given erythromycin orally. For children, it's weight again, and for adults, it's based on the dosage for adults. We're not going to go into that one today. Now, what is rheumatic fever? Rheumatic fever is an inflammatory, non-suppurative sequela of group A streptococcal upper respiratory tract infections, scarlet fever, or after strep skin infections, which is impetigo, with a marked tendency to recur. It mainly affects the large joints, the heart, the skin, and subcutaneous tissues. The diagnostic criteria is based on the modified Jones criteria. The pathophysiology is where the first episode of pharyngitis is unlikely to lead to rheumatic fever. So the first time an individual is affected by the group A beta hemolytic strep organism, it does not mean that that first episode is going to lead to rheumatic fever. However, the group A strep infection precedes clinical manifestation of acute rheumatic fever by 2 to 6 weeks. This means that if the strep throat is not treated within 2 to 6 weeks after exposure, then this individual will start showing signs and symptoms, which would be classical for rheumatic fever. The body produces antibodies against the streptococci. So when the individual is infected with the strep organism, the body now responds by producing antibodies against the organism. These antibodies cross-react with the human tissues because of the antigenic similarity between the streptococci components and the human connective tissues. And that is called the molecular mimicry. Immunologically, the immunologically mediated inflammation and damage takes place in the human tissues, which have antigenic similarities with the group A streptococcal bacteria, which is the heart, the joints, the brain, and the connective tissues. This diagram is just highlighting what was just said. So we can see my cursor where the individual's throat is now sore because it's infected with the organism, the beta hemolytic streptococcus bacteria. Now, when the body recognizes the presence of this organism, the lymph nodes are now going to be very active. So we'll see where the B lymphocytes are producing now these anti-strep antibodies. The anti-strep antibodies are going to be circulated through the blood, and because of the similarity of the connective tissues of the heart, these antibodies are in turn will affect the heart instead of affecting the organism that is causing the problem. And that's how we end up having the acute rheumatic heart problems. So what are some of the signs and symptoms of rheumatic fever? But before I go any further, I'll just pause to say, ask a question if everybody is understanding the pathophysiology thus far. Just give me a yes. I guess silence is consent.
Yes,
Let's go
Madam
on.
Doctor.
Thank you. So the signs and symptoms of rheumatic fever, these include fever, and this temperature is above 38 degrees Celsius. They'll have arthritis where they have painful and tender joints, and it's most commonly in the knees, the ankles, the elbows, and the wrist. And just to say that this type of arthritis is migratory, meaning that the pain will be in one joint at this time and then it moves to another joint. So it doesn't stay in a particular joint all the time. There also may be symptoms of congestive heart failure, including chest pain, shortness of breath, and palpitations. There's fatigue and chorea meaning jerky, uncontrollable body movement, which is different from a seizure activity. And this is just a pictographic representation. Fever 100.8 to 102, the erythema marginatum, the narrowed valvular heart, and this is only seen on echocardiogram and the painful joints. And that's another representation. So there are some differences. So anybody can have a sore throat, but it doesn't mean that all sore throats are caused by the streptococcal organism. So if we see a child between the age of 5 to 15 years old with a fever, then we'd want to think, with a sore throat, then would want to think that it's possible that it could be that this child is having a strep infection. However, not all sore throats, as I said before, is caused by strep. And so we have other things that would have to look out for. Now, for a strep infection, the mode of onset is sudden. So this child will just get up the morning and just have sudden onset of severe pain and difficulty swallowing. pain to the throat and difficulty swallowing, while for the other types of sore throat, it may come on gradual. So they wake up in the morning, they're having some pain, but as the day progresses, it gets worse. The initial symptom for a strep throat is where the sore throat, they'll have pain on swallowing, while the other type of sore throat, they'll have just mild sore throat. For the fever, we said over 38 degrees Celsius, while for someone with a non-strep throat infection, they might have fever, but it's not high. Now we want to look at the appearance of the throat, which would be classical. For the non-strep throat, they'll just have a redness of the pharynx, but for the strep throat, they have redness, they have swelling, and they'll have exudates. And the exudates are white fleeks. We call it pus on the tonsils for persons to be able to understand better in layman term. Enlargement of the tonsils with exudates is classical. And they also have punctuated hemorrhages in the soft palate. And those are the classic signs and symptoms of a strep throat. Other signs would include tenderness of the anterior cervical lymph nodes. They have scabby erosions or may have scabby erosions on the edges of the nose, and the clinical picture of scarlet fever if the individual was exposed to scarlet fever. However, other signs and symptoms for a non-strep throat, they may have they do have a cough, they'll end up with hoarseness, they'll have watery nasal secretions, and conjunctivitis. And that will tell us the difference between the strep and non-strep throats. Diagnosis and management. How do we diagnose? As we said before, that it is diagnosed using the Jones criteria. And the Jones criteria, it spells out the name, Jones, and each letter represents one of the affected organ in the body or structure in the body. So for J, it's the joint, and we're looking at polyarthritis, and the Jones are the major criteria. So polyarthritis, the O, carditis, the N is for nodules, so it's a subcutaneous nodules, E for erythema marginatum, and the S for sydenham chorea. The minor criteria are arthralgia. There may be prolonged PR interval when an ECG is done. They'll have fever, elevated ESR, or CRP. And the Jones, for diagnosis of the Jones criteria, there must be 2 major or 1 major and 2 minor with evidence of recent group A streptococcal infection. And I'll just repeat that. In order for a diagnosis of rheumatic fever to be made, the patient that presents to us must have 2 major, so they can have the polyarthritis and sydenham chorea or any other, or they may have 1, so they may have joint pains along with elevated temperature, elevated ESR or CRP, and a recent group A strep infection. All right, so diagnosis and management continues. For rheumatic fever, as we said, it affects mainly the large joints as arthritis and the heart. The 2 major organs are the musculoskeletal systems. Sorry, the 2 major systems are the musculoskeletal systems and the cardiovascular system. So they'll have the arthritis and carditis. Less frequently, we'll see them with chorea, erythema, marginatum, and subcutaneous nodules. The child with rheumatic fever usually has fever, joint pain, and swelling involving several joints. And as was mentioned, it's migratory polyarthritis. The larger joints, the knees, the ankles, the wrists, or elbows are more commonly affected. There is frequently more pain than swelling as opposed to like osteoarthritis. Migratory polyarthritis is the rule. When you're looking at arthritis now, as we said again, just for repetition, migratory polyarthritis, it affects the large joints. There is redness, warmth, swelling, limitation of mobility. The onset of this arthritis is sudden and it lasts 3 to 7 days, but it subsides and reappears in the other joints. Usually it lasts 1 to 5 weeks and it subsides without residual deformity. A prompt response to therapeutic doses of salicylates, which is aspirin, or NSAIDs, NSAIDs, for example, Voltaren or Cataflam, is characteristic. Carditis is an early manifestation in 90% of persons, and it occurs within the first 2 weeks, within 2 weeks of onset. There's pericarditis, where you have precordial pain, friction rub, ST and T changes on ECG, endocarditis, where there's pansystolic murmur of mitral regurgitation, whether or not there is arterial regurg murmur. There's cardiomegaly that is detected by physical signs, X-ray, chest X-ray, and echocardiogram. There may be congestive failure, whether right or left-sided, and there might have mitral or aortic regurgitation murmurs. Sydenham chorea is where you have neurological involvement, and it's a late manifestation in 10 to 15% of persons, and it occurs 3 months after the onset. Chorea is purposeless, involuntary, rapid, jerky movements, often associated with muscle weakness, emotional lability, explosive or halting speech, and a behavioral abnormality and facial grimacing. It is exacerbated by stress and it is relieved by rest. It's more common in females, and it's usually on the face, the tongue, and the upper extremities that are affected. It is the most diagnostic manifestation of rheumatic fever, and it is self-limiting. And this is how the individual will present or they look when they have Sydenham chorea at different points in time. And just to say that it's involuntary. So sometimes you may see the child behaving like this, and you say, sit down and behave yourself, but it's involuntary. So when we see something like this, then we know we have to do a further investigation. The erythema marginatum is an early manifestation in less than 3% of persons are affected. This is a distinctive effervescent, pink rash that begins as enlarging macules, ring-like or crescents with a pale center and a round or serpiginous margin. The size may vary, and they occur mainly on the trunk or the proximal extremities, but they were never on the face. The erythema is transient and migratory. It worsens with the application of heat. The rash is non-pruritic, non-indurated, and it blanches on pressure. The erythema marginatum is a rare manifestation of rheumatic fever. It's often associated with chronic carditis, and that's why it's a late presentation. And this is what the erythema marginatum looks like. And this is how it looks in a lighter skinned individual. Subcutaneous nodule is also a late manifestation, 6 weeks after the onset, and 3 to 20% of persons are affected. It's a firm, painless nodule. It may present over the extensor surface or certain joints, such as the elbows, the knees, and the wrists. They may also appear in the occipital region or over the spiny processes of the thoracic and lumbar vertebrae. The overlying skin is mobile and not inflamed. These are rare and most often associated with the presence of carditis. And they are pinhead, to almond in size. And this is what the subcutaneous nodules look like. So when we speak of minor criteria for the diagnosis, we're looking for fever, polyarthralgia, reversible prolongation of the PR interval. The persons may have first-degree AV block, rapid erythrocyte sedimentation rate, and evidence of an antecedent beta hemolytic streptococcal infection. There's increased CRP or the ASTO, leukocytosis, or a history of rheumatic fever or recent scarlet fever. There may be a positive throat culture that is supporting evidence of a preceding infection within the last 45 days. So our investigations would include the raised erythrocyte sedimentation rate, the CRP and leukocytosis, and those are non-specific to rheumatic fever, but those are inflammatory markers. So we definitely know when these are out of range, we know something is going on. But what are specific to rheumatic fever are the positive throat swabs, the ASTO titers that are normal in about 1/5 of cases, and it may be normal because of the timing when it is done. So within the first 45 days, sometimes persons don't seek medical attention. What they do, they'll stay home and they'll just use home remedies. And so it might be normal in these persons if they did not seek care within that 45 days period. ECG and echocardiogram, we want to look at the heart, and we want to look also at the valves of the heart. And chest x-ray, again, we want to look at the heart because we want to rule out carditis, because not all persons have carditis. So how do we manage rheumatic fever? First and foremost, we need to take a detailed history because we want to find out why is the person, if the person had a sore throat in the past, and how many episodes of sore throat, and if they were treated. We also want to know if they were in contact with other persons who had sore throat as well. So we know that they may be contact of this organism. Now we want to find out the reason for them seeking care. Again, a lot of them would not come because of the sore throat. They'll come because they now start having joint pains or palpitations, which now they become anxious because of these new signs and symptoms. You want to review the systems. So there's main systems. You want to look at the skin for rashes, itching, redness. The musculoskeletal system, they want to assess for the joint pain. So if they have pain and movement of the joints, the swollen red joints, you want to look for the subcutaneous nodules. The cardiovascular system, you're looking for you're assessing for chest pain. You're looking for palpitation, shortness of breath, and find out if they are tired, any recent fever, and weight loss or weight gain or loss of appetite. You want to review for dangerous signs, which may require immediate referral to hospital, and these include cyanosis, sore throat, active sore throat, shortness of breath or dyspnea, temperature greater than 38 degrees Celsius, a pulse rate less than 60 beats per minute or greater than 100, chest pain with inadequate supply or non-compliance with medication. So some of these persons, they may have, why we say non-compliance with medication is because some of these persons who present with rheumatic fever or present with these signs and symptoms would have been persons who were previously diagnosed with rheumatic fever. So I want to find out if they were diagnosed and if they are compliant with their medication, because they can be reinfected. We're going to conduct our physical examination. So we're looking on the skin for erythema marginatum. They look at ENT for signs of strep throat, musculoskeletal system for the subcutaneous nodules and the swelling and redness. I want to auscultate the chest sounds for murmurs, whether mitral, aortic, regurgitation, or tricuspid. Now, how do we manage these conditions is through antibiotic therapy. I would have gone through this already, so I'm not going to spend much time on it. But all patients should be started on long-term antibiotic prophylaxis. But just to point out that after getting the initial treatment, as I said, some of our individuals, they may not come to us in the initial stage. If they're actively having a sore throat, then you're going to treat them for the 10 days. If not, and they would have fit the criteria, would start them on the long-term antibiotic. We manage arthritis or arthralgia with aspirin. And usually it is for 4 to 5 days. Severe carditis we manage with corticosteroids, prednisolone, and we taper down after a while. For the sodium chorea, it's haloperidol, 5.5 milligrams per kilogram per day, or carbamazepine, or sodium valproate, and NSAID for the pain. All suspected cases of rheumatic fever must be referred to hospital for diagnosis and management. So we have some clinicians who would just go ahead and treat them, but it is recommended that they should be hospitalized. And the goal for hospitalization is one, you want to treat to eliminate the strep throat. You want to treat them for inflammation and CCF, and you want to ensure that they get appropriate rest and supervision while they are being treated. And if they are treated in the initial stage in the health centers, they cannot be effectively supervised. And, you know, sometimes we send our patients home and we put them on bed rest, but they don't stay in bed. Non-inflammatory drugs are given until the diagnosis is established. So we use acetaminophen. So when even if we suspect that this person has rheumatic fever, we should not start them on aspirin or the NSAIDs. We should give them acetaminophen, because these medications, they are going to relieve the pain, relieve the inflammation, and so it would be difficult to identify the real issues that are there. So it will mask the real issues that the patient is presently having. And just to say that rheumatic fever is a class 1 notifiable condition. And so within the first 24 hours of suspecting that this individual has rheumatic fever, it must be notified so it can be investigated appropriately. So now down to our prevention. How do we prevent rheumatic fever? Is rheumatic fever preventable? And how do we prevent the condition? First and foremost, we want to say that yes, it is preventable, and we can prevent it by covering all coughs and sneezes. We should not share personal items, example, drinking glasses or eating utensils, and we should wash our hands frequently. And this is because the organism, the group A beta hemolytic streptococcal bacteria, can spread through coughs and sneeze and drinking or sharing personal items. And if the cough etiquette is not practiced, where we cough in our elbows instead of in our hands, then we are up for a big problem there. And 5 moments of hand hygiene. So even though we are speaking about the individuals in the community, but nurses or healthcare workers, we know about the 5 moments of hand hygiene, and we can apply them to the wider community. So before touching a patient, we should wash our hands. And I would tell the patient, before touching your face, wash your hands. Before before clean or antiseptic procedure, we should wash our hands. We can tell our patients before eating or before putting their hands in their mouth, they should wash their hands. After body fluid exposure, we'll tell our patients, after touching the doorknobs, after sneezing in your hand, after blowing your nose, after coughing with covering your hand with your covering your mouth with your hands, you should wash your hands. After touching a dirty surface, so after touching a patient, but for the community is after touching any dirty surface. And sometimes the surfaces may look clean, but they have the organisms there and we'll not see them with our own little eyes. And after touching the patient's surrounding. So basically we tell our patients, after touching anything at all, before eating, you should always wash your hands. To helping to prevent the spread of respiratory disease, we let them know that they should avoid close contact with people as well who are sick and stay away from others so that they do not spread the germs to everybody. That's another method of prevention of rheumatic fever. The main ways to prevent rheumatic fever are, one, to prevent the group A strep infection by doing the things that we would have mentioned initially, to treat group A strep infections with antibiotics to ensure that all sore throats are treated properly and effectively. And we encourage our patients that once doctor prescribes a medication for you, to ensure that they take all the medication until it is finished. Do not leave some for the neighbor or the other child when the child gets ill, but to take it all off. And would want to explain to them the reason behind that in terms of the antibiotic resistance that may come up because of the fact that the organism is not properly treated, and also to use preventive antibiotics for people who had rheumatic fever. For example, dental prophylaxis. Just a diagram illustrating the different levels of prevention for rheumatic fever. So the social determinants, as was mentioned, we want to reduction in poverty. We want to reduce inequality and crowded living conditions. And if that is done, then the risk of someone getting the strep organism would be less. Also, we want to improve access to healthcare. Access to healthcare because persons may be living far from the health facilities. 1, 2, they may have a health center, but it is not functioning. And so they may not be able to afford to go to another health center or a hospital in another community. And so that would cause them now to stick to home remedies. So if we improve access, then we can prevent rheumatic fever by ensuring that the sore throat is treated within the particular time to prevent it. Primary prevention, treating the strep A infections with appropriate antibiotics. And yes, we mentioned that there's no vaccine for strep A. And so a method of prevention is to develop a strep A vaccine. Secondary prevention is to improve awareness and diagnosis of acute rheumatic fever, and to the register of persons living with acute rheumatic fever, rheumatic heart disease. So if we have a register that can say, we can indicate the number of persons living with the condition, persons will become more aware of the fact that, oh, this condition exists, and try to find ways and means of preventing it, or basically stick to the preventative measures that would have been listed before. Regular antibiotics for people at risk of acute rheumatic fever recurrence, like those persons who already had an occurrence of rheumatic fever and was discharged. And we know that these persons are at greater risk of getting rheumatic fever again. And so we want to protect these persons to prevent a recurrence. Tertiary intervention is that medications to manage complications for rheumatic heart disease. Now, for tertiary prevention or intervention it will come into play because it's like a domino effect. When you're exposed to the organism, you get your sore throat. If you don't treat your sore throat, you end up having rheumatic fever. If your rheumatic fever is not properly managed, you end up with rheumatic heart disease. And if rheumatic heart disease is still not properly managed, then there are other complications of rheumatic heart disease that I will list later on. And so we want to make these medications available so that we don't have the complications of the heart disease. We want to make sure that they have access to anticoagulation and access to surgical intervention. And you'll understand why later on when we discuss rheumatic heart disease in short. So how do we control or manage rheumatic fever? Secondary prophylaxis. So once the individual is diagnosed with rheumatic fever, they are placed on long-term therapy. And this long-term therapy is called secondary prophylaxis. And the secondary prophylaxis is by way of the benzathine penicillin, and it is given every 2 weeks while in hospital, but every 21 to 28 days after discharge. The dosage is, if the individual is less than 30 kilograms in weight, they get 0.6 mega units, and if they're more than 30 kilograms, they'll get 1.2. For those persons who are allergic to penicillin, then they'll get erythromycin 250 milligrams twice daily. Now, for persons who are 1 to 5 years old, they'll get 125 milligrams, and those persons 6 to 12 and beyond will get 250 milligrams. Now, the oral medication is not just for those persons who are allergic to penicillin. Also, sometimes some of our patients will travel abroad and they cannot get the benzathine penicillin while they're outside of the country unless they have someone in the US or wherever they go that will prescribe and administer. And so when they're leaving, they'll tell us that they're leaving, and so we'll place them on the oral therapy until they return. The duration of treatment is individualized. So if there's no carditis, so the heart is not involved, then these individuals will go up to 5 years after the last attack. And I stressed last attack because the last attack is from the last time that the person would have had a recurrence of a strep throat. So this person may have been diagnosed with rheumatic fever in 2010, and they're expected to go up to 2015. However, when that individual was 2014, in 2014, that individual went to visit a family member. Everybody within the household was ill. And so this individual would have contracted the same organism, the beta hemolytic strep infection. And so this individual cannot stop in 2015 anymore, but the 5 years will have to restart from 2014 when that person had the last attack. Or until age 18, whichever is longer, yes. But again, if the attack happens at age 17 and the person was supposed to stop at 18, we have to restart the 5-year count. And that is why it is said that it is individualized. Those working with high-risk groups should continue until 25 years. High-risk groups meaning if they're in daycare centers, they work in the schools, they work in the hospitals, they go up a little longer. And we know why. The risk of contracting is greater. If there is cardiac involvement, then these persons have to be on these medications for life. If they have a healed carditis, they go up until they are 25 years old or longer. The treatment is discontinued only by a cardiologist. And sometimes some of our patients, they will go have their echocardiogram done or they will tell, before they even do an echo, they will tell the doctor that they were told from the time they were diagnosed that when they are 25 years old, then they would stop. But even if they're 25 years old, they cannot just stop like that because of the fact that there may be damages to the heart that was not identified. And so these individuals, before they discontinue treatment, must have an echocardiogram done, and they must be discontinued by a cardiologist. When a female gets pregnant, the treatment must continue during pregnancy. And we know the different things that can happen in pregnancy. Pregnancy in itself puts stress on the body. And so the additional stress on the heart can make the condition worse. And so it must be continued during pregnancy. Appointments must be given to the nearest clinic or hospital, and it's every 21 to 28 days to accommodate weekdays. So 21 to 28, and we wonder why we don't stick with one date. The thing about it is that some persons, when they reach day 28, they start having pains. Some of them, they would miss their date for whatever reason. And so if we give them 21 days, once they are outside of that 28 days coverage period, they are at risk of contracting, are being exposed, not exposed, but they are at risk of having recurrence of rheumatic fever. And so we want to ensure that our patients remain safe. And that's why we say 21 to 28 days. So it's every 3 to 4 weeks. For persons who are on tablets, we want to do a count. So we count the amount of tablets in the bottle. Now, these patients are very smart, and some of them, they'll throw away the tablets because they know they're not taking it. So it's not a safe way of ensuring or assessing compliance, because they'll throw away the medication. They'll empty it up before they come to you and bring the container to say, see, which is not true. And so it's difficult to determine compliance in the persons who are taking the tablets. These persons must have their medical exams done at least once per year. And our patients now are being treated as how we treat our chronic patients, our patients with chronic diseases. So the persons who have diabetes or hypertension, for example, they would get a 5-month or 6-month appointment. And so the same thing is being done for my patients who have rheumatic fever and rheumatic heart disease. We want to ensure that sore throats are managed effectively. And as a measure of control is that once the individual has sore throat, they are at risk of having a recurrence of rheumatic fever. And the fact that the individual has rheumatic fever does not make them immune of getting recurrence. And so we want to ensure that their sore throats are effectively treated. We want to give prophylaxis prior to invasive procedures. So for adults, we give amoxicillin 2 grams 1 hour before the procedure. And for children, it is weight-based, so it's 50 milligrams per kilogram 1 hour prior to the procedure. For persons with penicillin, we give azithromycin or clarithromycin, and or clindamycin as well. And the pre-dental prophylaxis would be what I just made mention of, that they're given. And the reason why we give prophylaxis prior to dental procedures is that the organism that is within the teeth or tooth that they're having issues with, the organism there can also affect the heart. If the heart is already compromised, we don't want to have anything adding to the issues that the patient is already having with the heart. And so we protect the heart by giving the prophylaxis. We do ongoing monitoring as a measure of controlling the condition. We do continuous health education. So we continue to educate our patients on the conditions and the complications, the danger signs to look for, and what measures to take, ensuring medication compliance, family planning measures, and it's it doesn't mean that because an individual has rheumatic fever, they cannot get pregnant. However, it's also encouraged that based on how the heart is, they have to be assessed by a physician first to see if it is safe for them to get pregnant. And so we have to encourage family planning methods. Also, we want to encourage exercise because gaining weight can add pressure to the heart. And so we don't want them to, have any other thing adding to the already compromised condition or state of the heart. We want to tell them about nutrition. So cardiovascular system is already affected. We don't want to have them eating any and anything, and then their cholesterol goes up, they have plaque buildup and all of that, then they'll still end up, having a stroke, which can be a complication of the heart disease, as well as poor nutrition, dental procedures and prophylaxis. And just to let them know that invitation is open. Even if it's not their appointment, they can come in, they can talk to us if they have an issue. They should be on multivitamins and iron routinely to maintain good immune system. Now for the iron, we do routine blood tests. So not all our patients are placed on iron routinely. It's individualized, but we still need to let them know that we want their immune system to be top of the top. We want to ensure that their prophylaxis cards are taken care of, because say, for example, they get ill and they go to the hospital, they can use that card to say, see, I did get my prophylaxis on this particular day. However, this is a situation. So that can be helpful to the physician who is seeing him or her. Updated immunization card. And you may wonder what's the importance of, the immunization in rheumatic fever. But because this patient is already compromised, the different systems are affected, we don't want them to have any other condition or any other diseases that may further complicate their already affected systems, and ensure that they get their follow-up appointments all the time. Complications of rheumatic fever. And we say that rheumatic fever, if untreated, can lead to rheumatic heart disease. So in a synopsis, I'm just going to highlight rheumatic heart disease is a complication of rheumatic fever in which the heart valves are permanently damaged by rheumatic fever. Not going to spend much time on this because signs and symptoms is just an exaggeration of the ones that we would see in rheumatic fever, where the shortness of breath is more severe, especially with activity or when they're lying down. These persons too with rheumatic heart disease can end up with swelling, and it depends on which side of the heart that is affected too, because if it is the right side of the heart, they'll have this pedal edema, so they have swelling in the body, obvious swelling. If it is the left side of the heart, then they'll have more respiratory problems than physical swelling. The diagnosis is the same because we do the same test, it's just that we're looking for different things with rheumatic heart disease. So we go through that. And the treatment is the same, except that the treatment depends largely on how much damage is done to the heart valves. So in severe cases of rheumatic heart disease, the treatment includes surgery where they replace or repair the badly damaged valves. This is just a picture graphic representation of a normal valve when it's open and a abnormal valve compared to when it is closed. And we can see where the damaged or diseased valve, when closed, it can see it is not completely closed, and so you'll have backflow of blood, and that's when you hear the term regurgitation. So whichever valve is affected, then the regurgitation would come based on the valve. So if it's a mitral valve that looks like our picture here, then you have mitral regurgitation because you have backflow of blood. When it is supposed to be completely closed, it's not closed. Management is similar. As I said, You want to prevent the rheumatic fever, you give the anti-inflammatory drugs, and those are used to reduce inflammation and lower the risk of the heart damage. And the other medications may be necessary if they have heart failure. And in closing, I just want to highlight the complications of rheumatic heart disease, and heart failure is one such. This can occur from either severely narrowed or leaking heart valve, bacterial endocarditis, and this is why we also give the dental prophylaxis to prevent the bacterial endocarditis, complications of pregnancy and delivery due to heart damage. So when women with rheumatic heart disease should discuss their condition, as we said before, with their healthcare provider before getting pregnant. There may be ruptured heart valves. These persons can end up having stroke or arrhythmias. And this arrhythmia can be due to the damage to the valves of the heart, which causes a change in the shape of the heart, leading to the arrhythmias. Thank you.
Well. Thank you, Nurse Jones-Ellis, for taking us down that pathophysiology class. And our takeaway for this session will be our infection prevention and control strategies. Well done. I'm seeing Mrs. Chisholm Ford giving you a clap. And I know she's a public health nurse, so I mean, she don't play around. So when you see she give you a clap, you did excellent on this presentation. Now I'm asking the group to just hold their questions. We will have another presenter, and after her presentation, you will be able to speak with or ask Mrs. Jones-Ellis her questions, as well as our next presenter. All right. Our next presenter will be Nurse Andrea Fagan. Nurse Fagan is a graduate nurse with over 10 years experience. She is a certified infection prevention and control nurse who graduated from the University of the West Indies. She has a zeal for providing effective and efficient nursing care to all her patients and takes the opportunity to impart health promotion. She currently works at the National Police College of Jamaica in the capacity of a registered nurse and a member of the Infection Prevention and Control Committee, where she is responsible to develop policies and procedures governing infection prevention and control, along with to develop standards operating procedure for her department. Help me welcome Nurse Andrea Fagan.
Thank you. Thank you so much. Thank you guys for having me this evening. I'm having a little problem with my throat, but nonetheless, with the help of God, I'll be able to present and you'll be able to hear me. One thing though, I need assistance in getting the slides up and running, if you don't mind.
Okay, have you opened the presentation?
Yes, it is open.
Okay, go to share screen. Click on share screen.
Okay.
And then you click on the presentation you wish to share. And then you click on the word share.
Share screen from my...
Yes, look at the
Zoom.
bottom. I don't know if yours is the bottom or the top, but mine is some computers have it at the bottom, some have it at the top. So where you have share screen, it's usually in green.
I normally see, but I'm not seeing. Let me bigify, for want of a better word. Oh yes, it needed to be bigified.
All right, so you have to enlarge
yes.
it. All right. All right. Good. Yes, you are sharing your screen now.
All right,
All right,
go
so
to
what?
slideshow now.
Right, go to slideshow and then from the beginning.
Are you able to see? It's my screen. Are you able to see the screen?
Yes, we can see your screen.
From current.
No, go
Okay,
from
awesome.
beginning.
Is it much better now, right?
Yes, Andrew.
Wow, I started from there. All right, thank you very much. And good evening again, everyone. And thank you for having me. So this evening I'll be presenting on sexually transmitted infection. Been a challenge though. A part of my screen is taken up by but I see how it goes.
All right, what you
Right.
could do, Andrea, you could just put the cursor and pull it down and enlarge your presentation. Pull it across. Put the cursor, when you see that arrow, you
Mhm.
just enlarge
Oh.
it. Pull it right. Pull it to how you want it and
Okay, thank you. Are you guys seeing?
yes, we can see it clearly.
Awesome, awesome. So this evening we'll be asking the question, is the increase in is the increase in STI transmission a cause for public health concern? That's the question I'm posing. So sexually transmitted infections are a major public health problem worldwide, affecting quality of life and causing serious morbidity and mortality. Sexually transmitted infections have a direct impact on reproductive and child health, infertility, cancer, pregnancy complications, and thus impacting national and individual economic status. What is sexually transmitted infection by WHO and CDC? WHO, STIs are infections that are transmitted through sexual contact and can have serious consequences for sexual and reproductive health. CDC defines sexually transmitted infection as it refers to a pathogen that causes infection through sexual contact, whereas the term sexually transmitted disease refers to a recognizable disease state that have developed from the infection and morph into a disease. So I have a global statistics here by World Health 2020. It says that globally currently, and this was done 2020. So I would believe that it may have increased, whereas it could also have been decreased. Globally at that time, there was 374 million persons that were living in the world with a sexually transmitted disease. The sexually transmitted disease outlined were syphilis, gonorrhea, chlamydia, and trichomoniasis. The region that we lived in, which is the America, which comprise, I just name a few, the Caribbean, US, and Canada. At that time, 74 million persons were living with one of the above mentioned sexually transmitted infection. Also, in the European region, there were 23 million, Western Pacific region, 86 million, Southeast Asia region, 60 million, and East Mediterranean region, 36 million. And finally, the African continent with a whopping 96 million of their population. Also, World Health states more than 1 million sexually transmitted infections are contracted daily. So every day someone comes down with a sexually transmitted infection, which amount to 1 million per day. So this is now breaking it up out of the 374 million. So chlamydia, they had 129 million, gonorrhea, 82 million, syphilis, 7.1 million, and trichomoniasis, 156 million. Who are the persons at risk for a sexually transmitted infection? Individuals between the ages of 15 to 49 years who are sexually active, which includes women, men who have sex with other men, sex workers, transgender people, people in prison, and also persons who uses drug. One may say, why would a sexually transmitted infection come to a person who uses drug when it's possible that they could be injection needle or via the nares? It can come by the fact that a person may they can be distorted. The things that they would normally do, they are unable to do it because of the impact the drug would have on their system. So they could be a person that would be in their right mind to say no to sexual advances, but under the influence of drug, they may be able, or drugs rather, they may be able or not able to say no. So now we're moving into section 2, where I'll be speaking about the 4 conditions mentioned. Just a brief recap, and then we'll move into the infection preventative measures. So the first condition is syphilis. Syphilis is a systemic sexual bacterial infection caused by the spirochete Treponema pallidum. Syphilis is transmitted through sexual contact with infectious lesions or through a blood transfusion and from a pregnant woman to her unborn fetus. And here we have the diagram showing under the microscope the spirochete microorganism and also a person with the infection on their skin. So it manifested on the skin. Signs and symptoms of syphilis. So we have primary and secondary stages. So the primary stage, one may notice single or multiple sores to the following areas. So in the male, they may notice the sore at the penis or on the penis. In the female, the vagina, and in both of them, the anus, the rectum, lips, or in the mouth. Sores are usually, but not always, firm and round and painless. Painless sores is not normally noticed. However, the sore usually lasts 3 to 6 weeks and heal regardless of treatment or not. So now we are into the secondary stage. One may notice skin rashes, as I have just shown you, sores in the mouth, the vagina, anus. The rash can be on the palms of the hands or on the bottom of the feet and look rough, red, or reddish brown. How can one prevent syphilis? Syphilis can be prevented by having safe sexual practices, using condoms consistently and correctly. Also, screening can be done using rapid tests that can provide result in less than 20 minutes, allowing for immediate treatment. Complications of syphilis. So we have congenital, which is a complication of syphilis, which result or can result in stillbirth, neonatal death, low birth weight, that is birth weight less than 5 pounds 8 ounces or 2,500 grams, prematurity, that is infants being born before 37 weeks, neonatal conjunctivitis, and also congenital deformities. So we are at the second condition, which is chlamydia. Chlamydia is a genus of bacterial parasite that causes several different diseases in humans, but today we'll be focusing on sexually transmitted infection. Chlamydia is sexually transmitted and can occur both in men and women, and is caused by the bacterium Chlamydia trachomatis. In 2020, an estimated of 128.5 million new infections occur worldwide in the age group of 15 to 49 years of age. Chlamydia infection is more common in young people than in any other age group. So here is a pap smear sample, which is showing the microorganism. Signs and symptoms of chlamydia. So one may experience pain during urinating, also vaginal discharge coming from the penis, painful sexual intercourse in women, vaginal bleeding between periods and after sex. Also, in the male, they may experience testicular pain. Also, it can be cured as all these conditions with antibiotics. So we are now on to trichomoniasis, which is AKA trick. This is an infection. An infectious disease caused by the parasite Trichomonas. I'm sorry, I just got it wrong. Trichomonas vaginalis. It is preventable and curable sexually transmitted infection caused by the protozoan that infects the urogenital tract. Although the majority of infections are asymptomatic, meaning that they don't show symptoms, more than 50% of women with trich infection have a vaginal discharge, and about 10% of men have infection of the urethra. And here is a diagram showing the microorganism. Signs and symptoms of trichomoniasis. So in the female, they may experience yellow vaginal discharge that can appear purulent, red, or soreness to the vagina, pain during sexual intercourse, pain while urinating. And if you notice, this is a repeat of the signs and symptoms of the 4 conditions. Itching of the inner thighs, thin, greenish, yellow, frothy, or foamy discharge, vaginal or vulvar itching or swelling of the labia, or labia, whichever pronunciation works best. Vaginal odor or odor, foul or strong smell. Men may experience inflammation of the urethra, and also penile irritation, which is a burning sensation. And they may experience this on a regular basis before sexual intercourse or after sexual intercourse, which they shouldn't be having with the infection. Diagnosis. So there is a test that is used to diagnose TRIC, which is called the nucleic acid amplification test, also known as the NAAT. And it is the most sensitive laboratory diagnostic method for detecting the microorganism. Where whichever institution that does not have one of these diagnostic equipment, then signs or symptoms are done based on presenting symptoms from the vagina and from the urethra. Treatment. It is a curable condition, and it can be treated with metronidazole, which is the first line of antibiotic treatment, which is antibiotic and also a antiprotozoal. Also, it can be treated with tinidazole, and this can be administered orally. So we are on to another condition, which is gonorrhea. Gonorrhea is a sexually transmitted infection caused by Neisseria gonorrhea, also known as gonococcus singular, gonococci plural, is a species from the gram-negative diplococci bacteria. And here is a diagram under the microscope. So as you can see here, if you can follow the cursor here, these are the white blood cell, and here in the cell you find the microorganism here in bundles. Here again you can see the microorganism. Also we have here signs and symptoms on the forearm of a person. As you can see the same presentation here under the microscope. You can see here on the skin. Here they are. So another name for gonorrhea is clap drip, also known as clap or drip. Symptoms in female may include pain or burning sensation during urination, pain in the lower abdomen, pelvic or belly, white or yellow discharge, pain during intercourse, bleeding between periods, and also the symptoms in the male are white, yellow, or green discharge from the penis, testicular pain, swollen testicles, severe pain, or burning sensation while passing urine. Other symptoms may include in the throat, feeling an itchy throat, scratchiness, soreness, or trouble swallowing. Also, for persons who are involved in anal intercourse, they may have itching, discharge, and pain when the person passes stool. Treatment of gonorrhea can be given via the first line of treatment normally is ceftriaxone, which is 500 milligram is given. And that is if the person weighs 150 kilogram or 330 pounds. And if it is greater than the weight mentioned, then they may up the dose, and this is generally given IV to 1 gram. Also, if the person is allergic to ceftriaxone, the healthcare provider or the doctor who are working there may consider giving gentamicin, which the dose is 240 milligram plus 2 grams of azithromycin. And the azithromycin is prescribed to be taken orally. And a note, all sexually transmitted infection mentioned are treated and curable. They can be treated with antibiotics. However, if treatment is not forthcoming, the person may have the microorganism in their system for a period of time and has not completed their full dose, as my previous presenter has just announced, that persons need to take the full dose of the medication and not only leave some for tomorrow, a rainy day, or for another sickness, or for another child. Each person need to take the recommended dose of medication, of antibiotics as prescribed. It is your name on the medication, so it is you that needs to take it. And the physician that prescribe the medication, they can count, so they know in fact how many pills, how many IV medication that you need. As just announced, some of them is a 1 dose or a 2 dose, and that is all it takes. However, persons neglect to take the medication accordingly, and as a result, antimicrobial resistance may occur. So when antimicrobial resistance occur, as you have just heard me speak about this, for example, let's use the ceftriaxone, the 500 milligram for the first line treatment. If it is that the person, that's a bad example. Let me go back to this one. The gentamicin, if they are allergic to the ceftriaxone, so the gentamicin, so they will be given the gentamicin, and the gentamicin is given intravenously. So that is, they will be given 1 dose of which consists of the 240 milligram, plus they may be given 2 grams. This is to be taken orally. And the onus now is on the person. So the doctor, the prescriber, would have already given the IV dose, and this person now needs to go home to take the PO, the oral azithromycin. But for some reason or the other, they may not take the PO medication, and as a result, antimicrobial resistance can occur. And this is the microorganism can mutate, or on the other hand, it develop resistance. So the microorganism can mutate, or there is resistance to the antibiotic. So this antibiotic can no longer treat this particular infection. So what it tends to do now, you move from the first line treatment and you move on to another antibiotic which could use or can be used to treat this particular infection. And if the cycles go on and on, then the person may develop antimicrobial resistance to all the antibiotics. And if they develop resistance, then there won't be any antibiotics that is left to treat the medication, to treat the condition, the antibiotics. So there won't be any antibiotics that is left to treat the condition. And as a result, this person may have this strain that keep on mutating and lead out to the general population. A note here, let me just read what I have. Antibiotic resistance is a type of antimicrobial resistance, and it is not only to bacteria, but rather to fungus, fungi, plural, parasites, and viruses. So they can all develop resistance to these as well. You have all been a wonderful participants. So we are now into section 3. But before I go into section 3, which deals with the infection preventative and control measures, is everyone okay? Is everything fine? Let me check the chat. Could you indicate in the chat?
They will save their questions, and then at the end of your presentation, if they want, okay, I'm seeing, yes, I'm understanding.
Awesome.
Right. So let them save their questions. If they need any other clarity on this area, they'll ask it at the end. So you may
Awesome.
proceed.
Thank
Okay.
you very much, Nurse Silvera. So we are now on section 3, infection prevention and control measures to prevent sexually transmitted infection. So we'll be looking on primary prevention, secondary prevention, tertiary prevention, multimodal approach, allocation of resource, human and man-made, training of healthcare staff, patient and caregiver education, performance, monitoring, treatment, and feedback, and also surveillance. Primary prevention. Sexually transmitted infection prevention at all levels is the cornerstone of every country's economic status. Interventions is aim to prevent exposure to risky behaviors that can cause disease or injury before they occur through screening, immunization, and health education, also through abstinence, appropriate condom, and appropriate condom use. Primary prevention continues. Children and young adults should be geared with the appropriate information for their age before they start having sexual intercourse. And thus we have sexual education and health education. And this can be directed to the anatomy of the body, how the body develops, and the changes that takes place in the body, and also about sexual and reproductive health. Also providing information about contraceptive method, for example, in this case, male and female condoms, sexually transmitted infections. So you hear it about around sexually transmitted infections, also about childbirth, and about STI counseling. Secondary prevention. Secondary prevention aims to reduce the impact of the disease or the infection rather that has already occurred. This is done by detecting and treating the disease as soon as possible and to stop or slow its progress. It takes into consideration targeting the susceptible populations, the susceptible population at risk, screening, diagnosing, and treating. rather treatment. Also targeting the susceptible population at risk through health education, which includes men who have sex with other men. So we would not discriminate against them. There would be no stigmatization. There would be no inequality where resources are concerned. Also, adolescent boys and girls, there may be a stigma that says they are too young and should not be having intercourse. So therefore, if they come and need family planning, such as the condoms, we will not give it to them because they should not be having intercourse in the first place. Also, men who are sexually active, women who are sexually active, transgender people who might be discriminated against. There may be a stigma and also inequality. Also, to address promiscuous, risky behaviors, such as reducing the need to change sexual partners frequently, having one sexual partner with effective condom use reduces the risk of sexually transmitted infection. Also, if it is that you'll be having a new partner, discussion of testing once courtship begins reduces one risk significantly. Getting the media house involved, for example, YouTube, CVM, TVJ, involved by highlighting the necessary sexually transmitted infection preventative measures, which could include screening, diagnosing, and treatment centers, and highlighting the need for partners to be tested, not only the primary person, but also to encourage their partners to come in and be tested. And I know there are ads that is going around, but we can do more. While the ads is going around, you could highlight the areas, the centers that could do the screening, the diagnosing, and the treatment. And also, they could include the areas that the screening is being done to have a holistic approach where the screening, the diagnosing, and the treatment being done at one place. As you know, as previously mentioned, most of the treatment is just a one-off antibiotic treatment. So once the person is screened, diagnosed, then they could commence treatment. Also, administration of appropriate antibiotics treatment to persons who have been, I just said it. Tertiary prevention. Tertiary prevention seeks to reduce the impact of established disease by eliminating or reducing disability, minimizing suffering, and maximizing potential years of quality of life, and by maximizing potential years of quality of life. Tertiary prevention also aims to reduce the number and the impact of complications that the STI may cause, and which is done through therapy and rehabilitation in some instances, but not on the condition which I have presented, so I won't go into it. However, a complication of syphilis a complication of syphilis is congenital syphilis, which can causes hepatomegaly, and splenomegaly in an infant, also in a woman of childbearing age. pelvic inflammatory disease, and sterility both in men and in women. So we are now at section 4, which is the multimodal approach. So we look at the primary approach, primary, secondary, and tertiary. Now we are looking at the multimodal approach. And that is having a working infection prevention control program for sexually transmitted infection in all the institutions which are providing the screening, the treatment, and the diagnosing. And with evidence-based IPC guidelines, also educating and training of staff very frequently, whether it is once per month, quarterly, or annually, and also surveillance at the facility and at the national level. Allocation of resource, human and non-human, ensuring all points of care have the necessary screening equipment, regardless of where the location is. For example, it may be downtown or in an area that is prone to violence. However, we have persons that are living in those communities who would, in fact, be infected with one or rather have a sexually transmitted infection that needs the testing. So if it is that we can ensure that all testing sites have the necessary equipment, for example here, the nucleic acid amplification test, which is used to test gonorrhea and chlamydia. So all points of care need to have the necessary equipment. Also, adequate training of staff to ensure adequate running of the unit daily, which can lead to an increase in good behavioral practices and an increase in compliance, and thus reduce STI or time to come. So if it is that you trained your staff in dealing with persons, behavior, attitude, in using the equipment, in providing the necessary information to the clients, then the client will feel good and would want to come back. And also it would have a rippling effect. They will tell others in the community, yes, man, Miss Brown, Nurse Brown up at the center, she's nice, she have a wonderful personality, I like her. And when I go in, she treat me, look, I never see anyone treat anyone like that before. And remember, I had an sexually transmitted infection. She could have looked down on me, but no, she didn't. She treat me, she welcomed me, she just give me all the necessary information. She was polite, she was well trained, and she had all the knowledge regarding the condition I went there for. Also, patient, family, and caregiver education. Train staff, which is what I just spoke about, to the do's and the don'ts. Training on how to go about getting the partners to get tested. So if it is that Jane Brown comes in for testing of a particular sexually transmitted infection, which she suspected, for example, gonorrhea, and you, the staff, discovered that, yes, Miss Brown is, the diagnostic test shows that she is indeed positive. So training the staff in dealing with Miss Brown, in getting her partner, in coming to the facility to be tested and to be treated for the same condition. And that is, Miss Brown would not discriminate. She would not pity, regardless of, that is, sorry, the healthcare worker. Miss Brown is the client. So the healthcare worker, let's say the healthcare worker and Miss Brown, who is the client. So Miss Brown would not be discriminated against. She would not be pitied. and other persons regarded of their sexual orientation, their religion. For example, they are a Rastafarian, their nationality, they are not a Jamaican, but how dare they come to the facility for treatment, you know, things like this. And the group, whether they are white or black, you know, train staff, appropriate training of staff to deal with persons when they come in. Also, performance monitoring and treatment, and to give feedback. That is to perform regular monitoring and auditing of infection prevention and control practices to ensure that everything is up to standard, regular monitoring and auditing if necessary. And this is done to identify behavioral changes paired with feedback from the clients, also internal clients and staff members to identify if goals are being met, yes or no, or if there is a need for modification, or if it is working, then to continue with what is in place. And also surveillance of every facility, that is every Jackman child that have access to the facility. Their information is being taken, recorded, and become a part of the national level and then a part of the global level. Because when I was doing the research for this presentation, I could not find national statistics for our region, but rather it was lumped into the Americas. So if we have appropriate surveillance measures in place, then this can result in a few years down the line, another person is called on to present, then there will be national statistics and global statistics for the country. I'm not finding the information that I need on WHO, World Health Organization site for Jamaica statistics. So we need the surveillance from the facility, which feeds into the national level, which feeds into the regional level, which feeds into the global level. And also it allows for having surveillance, it allows for timely feedback on results and the commencement of treatment immediately after the results are made available to clients. And to summarize what I've went through just now, earlier we have read World Health Report 2020 report says that sexually transmitted infection is a major health concern that causes morbidity and morbidity, when in fact it should not, because the infections are treatable and curable. Sexually transmitted infection places burden on a country's health status and also on an individual. And as I said, it should not be, because these infections are treatable and they are curable. For a country to have a health status, for a country to have a healthy health status, the citizens must have healthy health and realize that for every action, there is an equal and opposite reaction. Thus, each sexually active persons must decide to modify their behavior and to make lifestyle changes. And in concluding, sexually transmitted infections are ongoing and it is going nowhere unless we as sexual beings modify our behavior and act responsibly. The statistics has shown 374 million cases worldwide. As we are here saying this number, it is increasing by the second. New cases are 1 million per day. Antimicrobial resistance is climbing daily, and very soon there will be no antibiotics to treat a curable infection such as gonorrhea, chlamydia, trichomoniasis, and all the other sexually transmitted infection unless pharmaceutical giants decide to make new antibiotics, which I can't see right now. Possible they may in the near future, but not right now. The impact sexually transmitted infections are having on health budget of a country can be significantly reduced if persons act and behave responsibly, also practice safer sex, or rather safer sex practices, abstaining from intercourse until marriage, because God initially had ordained for man to serve him, then man take on a wife, and then things happen after that. So if it is that you are not married, then you should not have any business engaging. And also, if it is that you are married, then it is recommended that you use a condom every single time during the intercourse to reduce the risk of contracting a sexually transmitted infection from your partner and getting the person with whom you have had intercourse to get a test done. If I may, I would like to borrow this adage: prevention is better than an ounce of cure. A few recommendations: make screening, diagnosing, and testing a priority in one location, and treatment as well in one location. Educate more on partner testing at point of care. Stop discrimination, stop stigmatization, ramp up having more screening centers and required screening equipment. Health education about knowing one's status, and your partner's status is not your status, or status rather. What can be done for those who are incarcerated? Health education, sex education can be taught in the penal institution and incarceration. Question and answer. Thank you for having me. Thank you so much.
Thank you, Nurse Fagan. For a moment, I thought I was in church.
I know,
All
right?
right. All right. Thank you so much, Nurse Fagan, for that presentation. And at this time, I'm inviting our attendees to post their question in the chat or just indicate with a raise of your hand if you want to ask a question. So, Nurse Fagan, I'm seeing in the chat, very informative. Let me see that again. Very informative. Reproductive health education emphasized, also client-centered care. All right. Do we have any other comment, or are there any questions for this presenter or Nurse Williams? Excellent presentation.
Thank you very much. Thank you so much. And thank you guys. You have been a wonderful participants by posting your in the chat.
All right, I'm thinking that everything was clear. And I have no questions being posed here. So, again, I want to say thanks to our two presenters this afternoon. And at this time, I will turn over to our president of the Omega Kappa chapter, Mrs. Cheryl Garrix Lloyd.
Thank you so much, Madam Moderator. Good afternoon, everyone. Let me just also say thank you to our presenters. This is our number 4 of 4 sessions for infection prevention and control. We have 2 days, tomorrow and Thursday, for the non-nursing sessions. And we really wanted to be able to keep our theme of infection prevention and control for the first 4 and the non-nursing, but for all 6, we wanted some things that were topical, things from a different perspective. And I would have to say, if you were following us for the last week, we've had a good 4 days of presenting, and we hope that everybody who is here who had joined us would agree with that. So look out when you get a little email to say, tell us what you thought, or what other topics would you like to see when next we have our series. And then also, everybody should know by now that there are a couple of questions that we usually throw out at the end. You know, we are sharing with you, and we said it at the beginning, so we're gonna close off with that we are happy to have you, but the point of our sessions is not just for the collecting of hours, it's for knowledge and application in the delivery of the healthcare that we do. So I want to thank both our ladies again this afternoon, our colleagues, and I want to say thank you too, because we would have covered a wide range of topics. Some of us got a little scared last week. This week it's not any different per se, just thinking about how we share, how we health educate and promote, but also from a personal perspective, because what if it's us? Maybe like me, you panic first and then you're like, wait, you're a nurse, you know, calm down, you've got this. If it's somebody for you or even your children. So you're learning about the rheumatic fever today and how serious it is and what can we do and why it's important to infection prevention and control. And we all have heard about the STIs, but we got some information. I think there was a staggering figure of how many million it is per day and constantly increasing. And we also got some idea last week as well about the microbial resistance and the fact that we are not doing well with the the antibiotics and the way we are giving them and or taking them at all. So for today, we have 4 questions. 4, the usual for the people who didn't join us before. If you're only coming on today, we ask you to type your questions, all the answers all at once, so we can see who gets the prize. Do not type them singly, but there are just some easy ones today because I was trying to follow along as the presenters. So if you are ready, I want you to start preparing your answers and start typing it up. And I will go over YouTube to check as well, because we do have people as we live stream each session and we also leave them over there. So from Nurse Ellis's presentation, I only had 2 questions today and 2 from Nurse Fagan. I want you to listen up. So the first question is, she gave a range for the fever that you may have in rheumatic fever. Started at 100 point something. So the first question is, what was the range of the elevated temperature in rheumatic fever? The second question is, she gave us an acronym and she said Jones. And I'm like, I've never even heard that one. So please tell me what the Jones is for. And since you were bright and paying attention, you know what the Jones is for. We're coming over to this presentation. So I want you to give me what's the name of the organism that causes syphilis. And then we also got a little acronym in here when she was giving us the multimodal and policy approach. She said we need to have all the resources we need, including the NAAT, N-A-A-T. So I need somebody to tell me what the NAAT is for. So it's 4 questions, you know. What's the range of the elevated temperature for rheumatic fever? What's the acronym Jones? What's the meaning of it? What's the organism that causes syphilis? And what is the meaning of NAAT? So I'm waiting on the answers to start coming up in the chat. And while you're thinking about that, we want to say to you that we have to do this infection prevention and control. Let me just take a few seconds while you're typing up your answers to say, we encourage everybody, please, I will personally tell you it's a pet peeve of mine when my colleagues just want to just type their names in a session for the hours, but we're not learning and we're not using it. I'm imploring us as nurses to be the change we want to see. We
That's
are
right.
as professionals who are usually left sometimes in the dark or not at the table at all when decisions are being made, though we are the ones who are 24 hours a day active involved in healthcare. Have your knowledge, stand from a place of knowledge and information, stand from a place of being a nursing leader, and let's jump in body first and get some of those changes we need to see. And let a lot of these initiatives be nurse led because we have the know how and the skill. We have the information. We know how to also plan it and implement it. We do nursing process till we're tired and we know how to get the results and we are the ones doing direct patient care. So I'm imploring us, please let us be the change that we want to see. And so while I'm waiting on the answers, because I don't see anybody typing it, right? So what is the range for the elevated temperature for the rheumatic fever? What's Jones? Somebody going back to their notes, right? What is the organism that causes syphilis? And then what's the meaning of the NAAT? If you have not joined us before either, I want to take this opportunity to say, as president of Omega Kappa, you will see my name on the screen, but I'm Cheryl Garrick Lloyd, and I lecture at the School of Nursing on UWI campus. I have the awesome task of being president of our chapter, outgoing though it may be, but we are a vibrant chapter of nursing students and nursing leaders. We are geographically at the UWI School of Nursing because we have to have a place, but our membership is across Caribbean countries, Jamaica, Barbados, Trinidad, the Bahamas, St. Lucia, Antigua, and we are also in the US and the UK. We are about Sigma is our parent organization. We call them Sigma because the long name is Sigma Theta Tau International Honor Society of Nursing. What they are about, mission and vision, is for us to have empowered nurse leaders who will impact healthcare anywhere, no matter where you are. And so we're consistently working on that. We are the only chapter in the Caribbean, and we're always, I would say, going about Sigma's mission and vision of trying to empower our nursing leaders, starting with our students who we have as members as well. And even if you're not interested in joining us, we ask you to partner with us for anything you see, make your suggestions, send us an email, follow our social media pages, Facebook, Twitter, YouTube. We are on Instagram as well. You will see what we're up to. We share our activities, we share our educational sessions. Like and subscribe to our YouTube channel. Every and all educational sessions we have pretty much get live streamed and or placed over there, and they are left for people to go back and get the information because we want everybody to be able to find it if you need it and to share it and use it wherever you are. So think about it and let us do that. All right. So we got a couple of answers over here. Give me a second to check over on YouTube. All right, so we got the causative agent for syphilis. Yes, ma'am, but I said write all of it in one, Daniel, right? Andrea McPherson, she said over 38 degrees Celsius is what she had. Then she had the joints, the carditis. Hold on. Disappeared right out of my vision. Hold on, let me come back up to it. Because Marlies is now entering the fray. Nodules, erythema, Sydenham chorea, the treponema, I would assume is for the syphilis, palladium, and she says it's nucleic acid amplification test. Both our presenters are on, so they'll be able to verify if these answers are correct. And then I have Marlee saying 108 to 102. Joints, the carditis, subcutaneous nodules, erythema, Sydenham chorea, treponema palladium, and the nucleic acid amplification testing. All right, so Valerie and Andrea, this is, how are they sounding? Closer, close-ish, right or wrong-ish? While you're looking at their answers in the chat, let me check over on YouTube. All right, so over here, we're just getting the comments. Thank you for your presentations. Very informative. And they want to just tell you thank you because they were both comprehensive. So I would say we have to decide over in the chat who's getting the prize today. That would be Andrea or would it be Marlies?
Andrea, because I'm seeing where Marlies, she has the treponema, and it is treponema. Look at the
Oh,
spelling
okay.
there. So Andrea is
For your
correct
two
for
questions.
the
All right.
microorganism, yes, and the NAAT.
All right. But
Marlies could have won, but because of, and sometimes this happen with the computer or the phone, it spell it how it want to spell it and not necessarily how you want it. So that could very well be the case with Marlies.
all
So
right. And then regarding the
For
first two
rheumatic,
questions, yes, Valerie, go right ahead, because Barney's look
so
like
for
she on
rheumatic, I
point.
would give it to Marlies.
Yes.
100.8
To
to 102.
102. Yep.
Yes, so the Jones criteria is also correct.
All
Jones
we have
right.
a tie.
polyarthritis,
We need a
pericarditis,
tiebreaker.
All right.
So
So based
Marlies
on what
coming.
I'm hearing, Andrea is the first to say we will share. Marlies, is there any agreement on this sharing?
We need a
Or
tiebreaker.
oh, you need a tiebreaker.
Yes,
All right. The
because
tiebreaker. Let me see if I
yes, it's
can find the tiebreaker.
they each got two correct.
All right. So the tiebreaker participants, because it's boiling down to the tiebreaker, I know. The
Yes.
tiebreaker I had written on here was of the primary
Oh,
prevention
but
given.
Andrea was saying, I'm sorry, Miss.
Yes, she
Yes,
was saying,
Andrea was saying we will share. So I'm no person to say otherwise.
but
So if
Marlies
they
is
want
asking
to
for the
share,
tiebreaker, right? Is that correct, Marlies? Oh, this is interesting.
so
Colleagues, the point
Marlies, would
is
you want to share with Andrea or you would
exactly.
prefer the tiebreaker? So it is up to both of you guys. You need to put your answer in the chat so we can hear you guys.
Madam Marlies, you're gone quiet. You tie breaking
I
or we
will what
sharing?
share? Oh,
Okay.
so they will share, which is awesome. That is what we need. So a little bit of something better than nothing at all.
All right, everybody, we want to thank you so much for joining us for completing this first section of our webinar, which are the 10 infection prevention and control hours. We had 3 lovely days last week and we've closed out this week. We want to remind you that within 4 weeks after we've completed the webinar is when the CE certificates will be emailed. So everybody who is participating needs to be registered. That is where we will get the information from. A reminder that attendance is necessary to get your CE hours, and Zoom makes a record or a register, so to speak, of the people who came in and the time you spent for the CE hours to be generated, and those will be emailed out to you. We really want to say thank you and hope that you had a great 4 days of that and getting the information you need to go back to bolster the IP and see that we're all going to be practicing. And then we continue tomorrow and Thursday with our series when we will have our non-nursing sessions. So if you didn't register and you're not sure, tell somebody else, remember to register. We are going to be talking about bullying in the workplace, mental health in the workplace tomorrow. And we close off our series on Thursday. We will be having 2 presentations again. The first one will be volunteering and volunteerism and its impact on you personally and professionally. And our last presentation of the series will be about creating multiple income streams. So we look forward to having you tomorrow because we want to talk about the bullying that's happening. Some of us don't even realize. Then we're going to talk about what each of us can do to ensure we are creating healthy work environments. On Thursday, we're going to talk a little bit about why do we need to volunteer? What does it benefit me as a person and how does it benefit me as a professional? And then everybody nowadays, we kind of want a little side hustle or a little other thing to help us out financially. So how do we go about making that something that we can really put ourselves into and create those multiple income streams? So we look forward to having you. Tell somebody. See you tomorrow evening. We start at 4:30 prompt. Remember to go over to our YouTube channel if you missed it, or tell somebody else if they missed it, because we keep the videos over there so everybody can see the sessions, and all the other ones that have previously gone are also there. And we also want to ask you if you have any interest in finding out more about our chapter. Omega Kappa chapter of Sigma. We are on Facebook. We're on Instagram. We are on Twitter. I'm sorry, X, formerly known as Twitter. We are on YouTube, and you can email us at the same place you sent your email when you were registering for this webinar series, so that you're able to find out more about joining our chapter. We have a criteria if you're a nursing student. We have one if you are also a nursing leader, and that's the requirement from our Sigma partner. It does involve that we pay our dues, and a portion comes back to the chapter to manage our affairs here. But more than anything else, I would say on Thursday, maybe we'll close off with a little bit more when there's a PowerPoint. In honesty, you have to ask the people who are members, because we have members in here. They benefit way more than what we pay. Even just from the hours of continuing education we're able to get, the academies we're able to join, and the networking opportunities. Sigma is in over 100 countries with over 135,000 nursing leaders. So we are out there. If you want to know about Sigma itself, just Google Sigma Nursing and their main page will come up, and you can have a little look for yourself and reach out to us at the email address omega.kappa.chapter560@gmail, or any one of us you know are in here that teaches at UWISON, reach out to us and they'll tell you who to direct it to, including me. So we thank you so much for joining us for the 4 sessions for IPNC, and we look forward to having you for tomorrow and Thursday as we close out with our non-nursing sessions. Have a wonderful evening, everybody.